Hi everyone, my name's Jess. I'm one of the London network leaders for Shine. In 2015, I was diagnosed with a chronic but incurable blood cancer and was managed to have fertility preservation before I started my treatment. I then had treatment for 2.5 years. And during the fertility preservation, I was single and used a sperm donor to create embryos. Straight after I finished my 2.5 years treatment, my ulcerative colitis started flaring, then my arthritis started flaring. And it's really been this kind of merry-go-round of illnesses. And as a result, I haven't used my preserved fertility. Unfortunately, I also then missed the window for NHS funding due to my age, and was able to privately fund another round of preservation last year because the first lot was corrupted by chemotherapy, which I've been on for about 20 years for my arthritis. So I'm really happy to talk about any aspects of that. I personally am still fertile, but I'm 43. So the chances are probably pretty small. And I don't know if I'm ever going to be well enough to use my preserved embryos. So that's a little bit about me, and really looking forward to the conversation today.
Thanks, Jess. And Cheryl, would you like to introduce yourself?
Hi, I'm Cheryl Fitzgerald. I'm a consultant gynaecologist and a consultant specialising in reproductive medicine in Manchester, at St Mary's in Manchester. Our unit has a very long history of storing sperm from men who were diagnosed with cancer and also other conditions that were going to affect their fertility. And then in 2008, we were very lucky to work with the local commissioners here, and we managed to set up a service here at St Mary's. So we've got a really quite a big NHS service here at St Mary's, and we obviously see patients when they're diagnosed with a malignancy, and offer egg freezing or sperm freezing if that's appropriate. And also, I think very importantly, which I think when I started this service, it was very much about that was the bit that was important. I think as the service has evolved, the thing that has become more and more important is actually helping patients after they've had their cancer treatment, because there are lots of bits then that kind of, well, you'll know better than I do. There are a lot of things that cancer treatments cause long term that mean actually managing getting pregnant can be quite difficult. So obviously a lot of our work now is in that. So happy to take any questions.
Thank you very much. So I think best place to start is perhaps with some of the questions that came through in advance of today's session, if that's okay. And feel free, as we're talking between the three of us, to drop your questions into the chat or raise your hand, and then we can sort of take the questions in that way. So I think one of the first questions that came in was, if you didn't have time or the opportunity to do egg saving and things at the time of diagnosis due to perhaps COVID and the imminent start of chemo, can I go back when I'm able? So for example, after the minimum required 2 years on tamoxifen, are my egg harvesting days over on the NHS? Currently, I'm unaware if I'm infertile or not.
So I think when you start talking about fertility, there are two things that you really need to consider. The first is clinically what we can do, and the second is funding. Now, funding, I can't really speak about because it's very different the country over, really. Here in the Northwest, I think we're pretty lucky. We have pretty good funding, but our funding is very much tied to some. So if we are looking at something like egg freezing, that is very much tied to somebody who is going to have some treatment which may increase their chance of infertility. So it's very much tied to imminent treatment. It's not tied to the diagnosis. So because you have had cancer doesn't mean you can then access egg freezing. If you're about to have chemotherapy because you've been diagnosed with cancer, then that is funded. So the funding argument is very difficult, very complex, it's all over the place. And I think you'd have to discuss that with the individual place that you went to. What is clinically possible will very much depend on egg reserve. So chemotherapy does reduce the reserve of eggs in the ovaries. So women are born with their eggs, we don't make eggs. And as we go through life, all that happens is that egg number goes down. And what happens is, if you like, so I'm going to do this the wrong way around, you're looking that way. If that egg number goes down and down, if you have chemotherapy, you get a shift, and it shifts down, if you like. And really, how much that shift has happened depends on how much chemo you've had and the dose of chemo and how long it's gone on for and all those things. But the only way to know if egg freezing is possible is to actually have that assessed. So if I saw somebody who'd had chemo and then came in and said, actually, I want to look at freezing now, even if, you know, that they might not be funded, they might self-fund, we could look at their egg reserve and give them a good idea. And certainly the evidence would suggest that post-chemo, it's not the quality of eggs that's gone down, it's the number. So actually during chemo, you can't freeze, and for a few months after chemo, you can't freeze because the eggs will be damaged. Long term, the eggs aren't damaged, they're just not there, that the number is lower. So certainly it will be possible to assess that, quite easily assess that, and if the reserve was okay, then actually look at either fertility treatment or freezing.
That's actually what I went through. So I was mid-treatment and realised my treatment wasn't particularly successful. So I took a second treatment to try and do some egg harvesting, but I was only 3 months out of chemotherapy, but also at the time by then I was 35, which I think, whilst I didn't necessarily feel old, I know it's quite old, 30 years. So that didn't necessarily help me, unfortunately, but at least I've got the opportunity to try that.
So I think it's one of the things that we found when we started this service. We were really well supported by the breast cancer services, and a lot of, and I think breast cancer, because it's around women anyway, they were quite kind of geared up for this really. Whereas and so we tended to get a lot of referrals from breast and from gynae, and everything else not really. And particularly the lymphomas, often first line treatment is not that toxic. So I think the oncologists and the hematologists kind of always thought, oh, it's not a big deal for us. But if you end up having to have second line treatment, then that is much more toxic. And the problem is, because you're only maybe 6 months or so from your first line treatment, you can't store successfully. So now, thankfully, we see all those lymphoma girls as well before their first line treatment.
And actually, one of the second questions, and it's also kind of come through as a similar theme through some of the questions that are coming through on the chat, is if you didn't have time or the opportunity to do egg harvesting at that point, sorry, ignore me. Sorry, if I wasn't able to save eggs due to needing to start chemo ASAP and the long wait time for egg saving treatment during the COVID pandemic, is there opportunities for them to now do that retrospectively, or would they? So,
as I say, the whole thing about so you need to look at the clinical situation and the funding, and they're really quite independent. So I think you'd have to look at, if you've had chemotherapy, is there still sufficient reserve to freeze, and that could be looked at. And then you would have to say, actually, is that funded? In most areas, I would doubt that would be funded, because it's very much tied to treatment you are going to have. And when NICE support fertility preservation, which was a big deal when they supported it in the review a few years ago, but they very much tied it to patients who are going to have treatment that may affect their fertility should be offered fertility preservation. So fertility preservation, it's a bit of a daft name, to be honest, because nobody can preserve fertility, but it's just optimizing fertility options, if you like. Now anybody can do that. You know, a lot of women in their early 30s who haven't got a partner may opt to try to freeze, but the funding really tends to be tied to imminent treatment.
Are they best speaking to their oncologist then at that point to try and get the referral sent through that way, or are they best?
I mean, I think the thing to do is absolutely just get referred into your local NHS IVF unit that looks after oncology patients. They can explain it all, because, as I say, it does vary so much from place to, and it will also depend on the ovarian reserve.
Thank you. One of the other questions were, what are the chances of finding sperm through surgery after a diagnosis of stage 4 testicular cancer with spinal metastasis?
So as far as, again, what I would think is you just have to be assessed. You know, you just have to go in. So we have some men who have very low sperm counts, and then there's no sperm in the ejaculate, and they need to have sperm retrieved from the testis. We can get a bit of an idea about the chance of that being successful from blood tests. So you can get an idea of whether you might have a chance, and if you might have a chance, then that is something that can be attempted. You know, sometimes I saw a patient recently who'd had previous treatment and is now having to have a load more treatment, and previously had been azoospermic, and we thought the chances of retrieving sperm would be very, very low. But actually we have managed to do that. So I think you just need to go and see the appropriate people and get your individual situation assessed, really.
Well, the thing is, I guess it's so individual, isn't it? It's such a case by case situation for each individual.
Yeah.
And also depends on their partner and their living situation as well, doesn't it?
Yeah, so for overall fertility, the partner's really, really important. But you know, I think you just need to be assessed individually, really, because there are some overriding principles. But patients do respond differently, you know, and some actually come through it pretty much, you know. I have my oncology clinic this morning, and you know, I saw a girl who's literally come through completely unscathed. You know, she's got loads of eggs, and you know, I think you can't always, you know, we know that what the average tends to do, but individual patients do sometimes respond quite differently.
I guess it also depends how many eggs you had before you went into chemotherapy, and I guess that's not something that most of us really ever kind of think about until.
No, and that, you know, that's very dependent on age, really. And I think, you know, the whole of society now is geared up to say, oh, you know, you can have babies in your 40s, and you know, and actually as a species we're designed to have babies in our 20s, and you know, so age has a massive effect on that. And I think that's one of the problems with oncology treatment. I think there are several reasons why that reduces fertility, and one of them is actually puts a spanner in the works for a few years. Do you know, so one bit is that, oh, you're going to have treatment which will reduce your chances of fertility. The second thing is actually we don't want you to get pregnant for 3 years. You know, if you're 17, that's not a big deal. If you're 35, it's a very big deal. And certainly looking at breast cancer and long-term tamoxifen and all that, you know, that in itself is something that can reduce fertility.
Yeah, age hasn't been on our side, has it, Jess?
Yeah.
It's
So
not on the side of anybody with 2 X chromosomes, unfortunately.
Can I just chip in quickly in response to some of the chat? So obviously we've got an hour. This is a massive topic for women and men, people of all genders, and we're never going to cover everything. It's also an extremely difficult emotional topic as well. And I know that I personally have really suffered on the mental health side, having my options either taken away or massively limited. And I might not have any anyway because of my health. We're not going to cover everything today, but we will take a note of the questions in the chat. I also want to highlight, we've got another session on Thursday with a professional counsellor who's going to look at some of the more emotional impact side. I think whilst I'm sure that Cheryl is extremely well versed in that, we want to try and give you as much of the medical side as possible today, but also making space for the real world impact, because we're all humans at the end of the day who had a plan for our lives that has been chucked in the bin thanks to cancer. So I just wanted to make the point, there are loads of different options, and we won't cover everything today. We're not trying to cover everything today, but we are looking at some follow-up work with Shine as well to kind of dig into some of these questions in a bit more detail.
I think we've got a question that's come from Charlotte. Is there any evidence that needing several rounds of IVF may raise the risk of reoccurrence of hormone positive cancers, such as an ER positive breast cancer?
I think we don't know, which is not the answer you want. So I think we know that if you get pregnant after breast cancer, it doesn't increase your chance of recurrence. That's quite safe. We kind of think that doing ovarian stimulation in the world of ER positive breast cancer is probably okay. Now that's not a very definite answer saying it's probably okay. But the problem is, and especially for ER positive breast cancers, they can recur many years down the road. And the trouble is, what we haven't got is we haven't got data from 20,000 women over 20 years. We just haven't got that data. The data that we've got, certainly from a fertility preservation setting for women who have eggs frozen when they're diagnosed with breast cancer is actually pretty reassuring. And there are also things that we can do in the world of infertility or in the world of IVF because obviously we're worried about estrogen levels, and there are things that we can do to keep that estrogen level down a bit as you go through treatment that hopefully should minimize risk. I think we can't say absolutely it's fine, but I think we are relatively optimistic that the risk is limited.
The other thing, sorry to jump in, Hannah, the other thing that I just want to make really clear, like this is a massively emotional topic. In the past, I've had to leave sessions on fertility at Shine Connect conferences because it's just been too much for me. Do what you need to do. The session is being recorded, so you can always come back to it later. But if it's triggering, basically, and you need to step away, that's absolutely fine.
Sorry, there's quite a lot of questions coming in, so it's trying to keep on top of the questions as they come through.
Yeah, so I've summarised a couple in a little group here. So there's been a lot of comments and questions about how you actually test for infertility, how you can tell if you're fertile or not. And I know the answer is different for men and women. So it'd be good to look at that. And there's another group of questions around how long after treatment is it safe to start thinking about these things, testing and maybe trying to have a baby, again, both for men and for women.
Okay, so first of all, there aren't any tests that tell you whether you're fertile or not. So we get asked that a lot, not just from patients who've had oncology treatment, but from fertility patients. There aren't, you know, I can't say to anybody, yes, you will have a baby, or no, you won't. That you can't really. What we do is we test for various bits. We do tests that look for problems, and we can say, actually, we haven't found any problems. But if you look at couples with fertility, just sort of regular subfertility, a quarter of them, all the tests are normal. We just don't know why it's not working. But I think the biggest thing from oncology treatment, really, so with the patients who've had pelvic radiotherapy are different. But if you look at patients who've had chemotherapy, who are in the majority, the thing that does is it reduces the number of eggs in your ovaries. It actually doesn't make you infertile. What it does is it reduces your duration when you can get pregnant. So women tend to go through the menopause at 50. I think the menopause is a bit of a hopeless term, to be honest, but it's still the one that's used. So women tend to run out of eggs at 50. To be honest, they start struggling to get pregnant from their late 30s. And that's because the number of eggs goes down and the quality of eggs goes down. What chemotherapy does is it reduces the number. It doesn't reduce the quality. So if you are trying to get pregnant naturally, just say you're 38, you've had chemotherapy, but you're having regular periods, your chances of getting pregnant naturally probably not different to somebody who hasn't had chemotherapy. But what happens is you haven't got as long to get pregnant because the eggs will run out earlier. And also, very importantly, if you end up needing IVF for another reason, say your partner's got a low sperm count, often you haven't got sufficient eggs for IVF. So a lot of women who have chemo, it doesn't stop their periods. It does for some, but for a lot of them, it doesn't stop their periods, but it very much reduces the number of years they've got in which to get pregnant. So one of the things I say to all patients that I see in clinic is that in the future, if they're thinking about a pregnancy, do it sooner rather than later, because it's that duration that's limited. And that's the thing that we worry about after chemo predominantly, is that egg number, that ovarian reserve. To actually check that, you can do that very easily from a blood test and a scan. They're very good markers. You really wouldn't want to do that until at least 9 months after you'd finished your chemo, possibly 12. Because eggs, bizarrely, we always tend to think they take about a couple of weeks to grow. They take about 9 months to grow. They take a very long time. So what you need to do is you need to wait until the little group that you've got back here have gone through that 9 month cycle, because all the things we measure are things that are released by eggs towards the end of their journey. So I think, you know, a good 9, possibly 12 months after you've finished your chemo, you can certainly get a good idea of what egg reserve is like. As far as getting pregnant is concerned, you definitely don't want to get pregnant within 3 months of finishing chemo. Now there are some chemotherapies that aren't so desperate for a pregnancy, but the worry really is that you're going to get pregnant with an egg which has been damaged, and that could cause fetal abnormality. So you definitely don't want to get pregnant within 3 months. And probably the same for men, really. It takes about 3 months for sperm to grow. I would think with men, for testing, you certainly wouldn't want to do it before 3 months. Sorry, I've just switched my colleague off. Within 3 months, and possibly maybe between 3 and 6 months, you could do a sperm test. It's quite easy to assess sperm, really. And again, you can't say in that sperm test, absolutely, you can have a pregnancy, but you can say actually all the numbers fall within what we would consider as normal.
It's really difficult that it is a lot. It's not emotionally any easier. There's no difference at all. But in terms of the actual science and the biology, preserving male fertility is a lot easier than preserving female fertility, because it takes one sperm to make a baby and it takes one egg, but men, every time they ejaculate, will produce millions of sperm, so they just need one that's any good. Whereas for women, we do have a lot of eggs, but we're born with our reserve, and only a few are released, if that, every month. So it is.
So I think the problem with fertility preservation, if you look at women freezing eggs, that's like an IVF cycle in a sense. So if you freeze eggs, if you're under the age of 35, maybe that's going to give you a 1 in 3, 1 in 4 chance of a successful ongoing pregnancy from freezing those eggs. You know, that's the average. So as I say, if you're a woman and you go through a cycle of fertility preservation, that gives you that chance. If you're a man and you bank sperm that would actually then be enough for 20 cycles of IVF. So your partner might not want to have 20 cycles of IVF, but if you were prepared to do that, then there's enough sperm to do that. Whereas eggs, it's 1 cycle. So I think it's very different. You know, it is easier to produce it, to bank, because it's just, you know, very easy to go and produce a sample. Whereas for women, it's a bit more protracted. Obviously, it's 2 weeks, injections and all that business. And then at the end of the day, a single ejaculate will give you enough sperm for many cycles of fertility treatment. Whereas with egg freezing, it's 1 cycle.
Yeah.
So, sorry, Jess.
I don't know whether it's worth mentioning if anybody on the call has got polycystic ovaries and the way that can impact treatment with cancer. And the second really strong theme, there's a lot of questions about hormone-driven cancers, which I think tend to be on the breast cancer side, but maybe not exclusively, as to whether, like, what it means if you have a hormone-driven cancer. Can you have IVF, or does the increase in the female hormones that causes put you at a much higher risk of cancer-related complications?
Okay, so first of all, we deal with the PCOS stuff. Actually, PCOS, if you have oncology treatment, it's probably a really good thing to have. Women with polycystic ovaries tend to have a very high egg reserve. They tend to run out of run out of eggs later in life. So actually, PCOS often makes it difficult to become pregnant because you often need treatment. But if we're looking at reserve, which is the thing, I know we keep going on, so ovarian reserve is the number of eggs you've got. And actually, if you've got PCOS, that tends to be pretty good. So actually, that's not a bad thing at all. Certainly not an additional problem. Actually, probably something that will help you. As far as, sorry, your second question was about hormone-dependent cancers. So as I say, you know, when you are pregnant, certainly for breast cancer, it does not increase the risk of your breast cancer coming back. And hormone levels are pretty high in pregnancy. both hormones really are quite high in pregnancy. As far as fertility treatments are concerned, it's just the answer I've said before, really, that we think it's probably okay. We do things to mitigate that risk. We can't say there's no risk. But most of the early data we have, certainly from patients who've frozen before treatment, suggests it's relatively safe.
So there's a question in the chat which basically is about NHS waiting times, and this is a really difficult topic because of the postcode lottery that the doctor mentioned earlier. For example, I started life in southwest London, which has completely different rules and that are much more generous than where I currently live in southeast London, even though it's literally a few miles away. So the question is about if you're not getting answers or even appointment dates on fertility with the NHS, how do you then proceed? Can you go private and then go back to NHS?
So
my initial suggestion is to go to your oncologist or whatever cancer doctor you have and get them to mark this as urgent, because they might have more influence than your GP. But I'll pass over to Dr. Cheryl.
Not really. It depends. I mean, basically, if you have had cancer and you are then referred in with infertility, you are sort of all infertility patients are treated the same, because actually all of our infertility patients are really struggling with infertility. Is a desperate diagnosis. Whatever has caused you to have it, it's an absolutely desperate diagnosis. I think it's a diagnosis people don't think is very important. I think those of us who work in this area know it destroys people. You know, we see a lot, you know, huge mental health issues in patients with infertility, relationships split up, you know, it's desperate. So all infertility patients who are referred for whatever reason will be treated the same. When you are about to have oncology treatment, there is a massive urgency to freeze, because you're going to start your chemo in 3 or 4 weeks. And I would hope, I mean, we certainly have I have a clinic every week. We see people at, you know, a day or two's notice. We get the referral on Friday, we see them on Tuesday, they start treatment that week. And that's, I think most fertility preservation centres do that. So I think it is quite, when it comes to actually, when you've come out the other end and looking at fertility treatment, there is a huge postcode lottery with that, and there are massive waits in some areas. And there is no quick way around that, really, because all infertility patients are desperate to come in.
Yeah. And the problem that I had in my lived experience is that I got the very urgent treatment before I started, and like Dr. Cheryl said, literally had an appointment and started my IVF prep the next day, which was horrendously traumatic, but I wasn't given any information on what happens afterwards. And I was just completely left in the dark, and some of the decisions that were made for me then have now affected my current position. So one of the things Shine is trying to do is provide some of that information up front so that more people don't go through the same traumas that some of the volunteers have been through themselves. It's a horrible situation, but I think that clarification I've personally found really helpful, that one of the key windows is before you start treatment or during your treatment. That's the time to be having those conversations. I
think the only difficulty is when patients are diagnosed. I mean, you know better than I do. You see an oncologist and you get about 1,000 stats thrown at you. You get 85% of this and 87%, and then this is 92%, and then we could do this, and then that would do that. And I think it's really difficult. And then along that way, you get stuck into an IVF clinic, and we're saying, right, you have to take these, and these are really important, you have to take the drug at this time. I think there's absolutely information overload. I mean, what I would say is just get in, get the the egg's frozen. Forget about the future for then. And what we say to all of our patients is 9 months after you've finished your chemo or your radiotherapy, you contact us, we'll do a blood and a scan, we can work out your egg reserve, and we can at that point talk to you about your fertility options. Because I think at the beginning, I think you can't take it all in. It's just too much information.
Yeah.
There's so much going on. I mean, I sat on the opposite side of an oncology appointment with my mum, not with me. And even listen, you know, as somebody who's medical, and it was, you know, it was my mum, it wasn't me. I was thinking, oh, I don't know how you take all this information. There's just so much. You're bombarded with all this information, aren't you? And I think then when you chuck fertility on top, so I would always say to people, look, just let's look at what you have to make the quick decision about. The only quick decision is, do you want to freeze? Everything else, just put it on the back burner and come and see us in a year's time when you're better. You know, because I think you just can't take it all in.
I think we've got questions that come in about uterine transposition. I don't know whether you know anything about
uterine transplant.
Yeah. Is it available in the UK is the question?
It's still very much in a, people are starting to do it, but it's still very, very much in a, not quite a research setting, but very much almost in that setting. It's not routine practice yet. It really isn't. It's extremely difficult.
And that's probably unlikely to become widely available for at least another 15 years, maybe longer, would you say?
I think you can't really,
can't even put a time on it.
You can't put a time on it. It might be quicker, but it's certainly something that has been around for a few years. And there's not massive, you know, organ transplantation is very difficult. A uterus is an organ that has to do an awful lot more almost than any other organ. If you consider when it becomes pregnant, it has to undergo such change. So still for women who haven't got a uterus, still the option really is surrogacy. And surrogacy is possible. And actually when it works, it's great. You know, we've had quite a few couples go through now who've used surrogacy. But it's emotionally difficult, it's legally difficult, it is never funded by the NHS ever.
Yeah.
And so it is difficult to go through, but it certainly is something that can be done.
I think also that was certainly available to me was donor eggs. So although I haven't got my own eggs, I've got all the equipment but nothing to put in it effectively. Absolutely.
So I think for women who have a low reserve or have no reserve, absolutely. So egg donation, you know, I don't think that's how anybody ever sets out to have their baby. You know, when you're 7 and you're pushing a pram, you're not thinking, oh, I'll do, you know, but actually that donor egg treatment is remarkably successful. It is actually pretty straightforward. Surrogacy is very difficult, but egg donation is actually very easy.
And my best friend has just had a baby using a donor egg from her sister. Obviously there's a whole world of mental health issues around that, and you know, I don't have any sisters, but it can technically come from anybody.
Yeah, and it's very successful, it's very straightforward. And actually about 3 to 5% of all IVF cycles now from egg donation. It's very common, very, very common, not because of oncology, but because of women.
So is that still possible for people that are either menopausal or postmenopausal?
Absolutely, yeah. You don't need any ovaries that can be taken out. Are there
any hormone risks then that would be associated to that, or perhaps would there be any implications if somebody's gone through an awful lot of treatment and their body or their residual side effects aren't necessarily fertility related, but perhaps have some other challenges? Is that something that people would need to take into consideration as part of that? Or do you think that actually their body will be able to cope with going to full-term pregnancy?
So if you just don't have, so basically estrogen comes from eggs. So men who have treatment, who can have treatment will stop producing sperm. It's quite unusual for them to stop producing testosterone because the sperm and the hormone come from different bits of the testes. In women, estrogen comes from the egg. So if you don't have any estrogen, you need to have that given to you through drugs, through pharmacology. But actually that works very well. It's really easy. It's just very easy. And as far as the risks are concerned, if you're worried about going through a cycle of IVF after, say, ER positive breast cancer, the risks of actually going through to have some, have the drugs for embryos to go back, that's much lower, much less. And actually, I can't really imagine, if you think about physiology, how that would increase your chance of a cancer recurrence over the pregnancy, really, because you have the drugs for 2 weeks and they're not particularly high dose. So, but absolutely, egg donation is possible. And I think, nowadays people are having really very, lots of different ways of having a family. It's not just, it's not as it was 50 years ago, as, donor eggs, donor sperm, surrogacy, all sorts of things that are possible.
It's worth saying, in case people aren't aware, that IVF isn't one thing, it's two things. The first part of it, if you have eggs, is stimulating the eggs and harvesting the eggs, then fertilizing it if you go down that road immediately. The second part of it, which can be done at a totally different time, is the implantation. And I think what you're saying, correct me if I'm wrong, is that the implantation second half may not have the same hormone related risks if you've got a hormone driven cancer.
I think it would have a lower risk. Yeah. We think they're both relatively safe, but the risk would be lower in preparing the uterus for an embryo transfer. Yeah.
And Cheryl, somebody's taken the egg donation to embryo donation, so that is something else that's also available to people, isn't it?
It is available. It's not very common, embryo donation. It's absolutely possible. We occasionally do get embryos from couples who've gone through fertility treatment. Maybe they've had 2 children and they decide they've got more embryos frozen and they want to donate them to somebody. So actually it's quite easy. It's a bit like, having egg donation as far as what you would have to go through medically. It depends a little bit. So, a lot of heterosexual couples that need egg donation, often they want to use his sperm. So it's not, and there's almost a bit of a mismatch of people who want to have donated embryos and people who are donating them. So it actually never really gets particularly well established, but it's certainly a possibility. So if you were somebody who is single, who needed donor eggs, then certainly, you could look at donor embryos as well. It would probably be easier to get donor eggs and a sperm donor than it would to get donor embryos, even though donor embryos are just, that bit's already being done. It's just the availability of them, really.
And there's legal issues as well surrounding whether they're both from people completely outside your family, unknown to you, etc., etc.
The legal issues for the recipient aren't really any different, to be honest, because if you have, once you get that embryo back, it's yours. It's nothing to do with anybody else.
Is funding still restricted if you're a single female or a single male? Is funding still more limited, or is that improved?
It has improved, but it's still, I think in the Northwest we're pretty well funded compared to other areas. But it's not common to fund single women.
So there's 2 issues here. One is for surrogacy and one is for IVF if you're single.
So they're not really different. The surrogacy hasn't really got anything to do with being single. Surrogacy is never funded on the NHS.
No, sorry. What I mean is until very recently in the UK, you couldn't apply to have a surrogate if you were single, but the law on that has now been changed. On IVF, some areas do fund you if you're single, and cancer can be very helpful. So I live in an area that does not fund single people, but did fund me because I had cancer. Whereas when I went back after cancer, as Dr. Cheryl said, I was treated like everybody else that's infertile and was told that they don't fund single people, which is discriminatory and illegal, but it is going to take time to change the law on that. And unfortunately, time is not something any of us have, particularly when we're diagnosed in our 30s with cancer. What other questions have we got? No, you go.
So is there any sort of new fertility options that are kind of coming through that people might not have heard of before, that perhaps is worth mentioning as part of this discussion today?
I think not particularly for adults. I think when we see children, so it's much harder for children because there aren't many options at the moment. You know, there aren't really options. But I think certainly by the time those children grow up, it's possible we may be able to make eggs, and we may be able to make sperm. Certainly in a research setting now, people are making sperm. Eggs are very, very difficult cells. Sperm are quite easy cells, relatively, whereas eggs are quite difficult. But I don't think it's, you know, so I go and see sometimes parents of, you know, children who are 2 or 3.
Okay.
And I don't think it's ridiculous to say to them that by the time their children grow up, if they haven't got eggs or sperm as a result of their treatment, then it's possible that people may be able to make them.
Interesting.
And there's things like, and there's you can freeze ovarian tissue as well instead of doing IVF cycles. Can you say a little bit about that?
Yeah, so you can freeze ovarian tissue. So it's a little bit limited on who you should do it on, because you need to be very confident that you're not going to put any cancer back in, because the only way to use that ovarian tissue is to put it back into the woman. You can't grow eggs in a lab. So it is being done. I think the people who do a lot of it would say it's as successful as egg freezing. It probably isn't quite as successful, to be honest. I think the problem is when anything's new, you always get a bit of reporting bias when stuff comes in, because all the early papers about how great something is. But that certainly can be done. I think if you can't really do both, which is the problem. It's quite hard you can't really fit in both. And I think as things stand at the moment, you're probably going to have a better chance from a cycle of egg freezing than ovarian tissue freezing.
There's also been a few questions about complementary therapies, both with regards to restarting periods, but also in terms of just getting a bit of sense of control over what you're doing. My experience with those is that I've had them during IVF and in my surrounding cancer treatment, and they've been brilliant for self-care and my mental health, but haven't had any specific physical benefits. Is there anything that you can say about that at all, please?
Yeah, I'd absolutely agree with that. Unfortunately, the data doesn't really support that they will increase your chance of keeping your eggs or getting pregnant or anything like that. But I think if they help people get through it, then absolutely take them, as long as you're not remortgaging the house to buy them. Absolutely, do anything you can, because you know, I think these are really difficult things to get through. But there isn't any evidence that they do actually make it more likely you'll become pregnant.
Is there any is there any complementary therapy that you'd be more of an advocate of than others, or is that kind of a...
No, not really. I think there are some that I definitely would be not an advocate of. So you know, I think herbs, I think all the kind of herbal things are a bit weird, and I think often they can make you look a bit better on paper, and they can actually make your chance of getting pregnant worse. Because you know, you can you know, the contraceptive pill will give you periods, but it won't make you fertile. So there are some things that can actually almost superficially make it look a little bit better, but they're not going to make a pregnancy more likely. So I think certainly some of the wacky herbal things I would steer clear of. You know, things like acupuncture, there is no evidence it helps at all, but if it helps you get through stuff, absolutely, that's great.
No, I do know a couple of people actually that have accessed reflexology, more for a relaxation perspective.
Absolutely, and it helps that, I think,
has actually helped them, conceive afterwards.
And also to say that there are a lot of quacks around who do prey on vulnerable people who are desperate and, you know, will borrow your watch to tell you the time and charge you for it, kind of thing.
No, I think absolutely. It's I think it's probably the field of medicine that is most or possibly almost most exploited, really. And you know, people who offer all sorts.
One question that's just today is, I take black, is it cobalt, and red clover. Can you take any hormones to give you your periods back so that it prepares your womb for implantation?
So I think there are two really important things. If you run out of eggs, there are two really important consequences of that. The one consequence is on fertility. And as we've said before, if you don't have any eggs, then the only way to have a pregnancy would be with eggs from a donor. Very possible, pretty straightforward. But the second big consequence is actually the effect on your body from having a lack of estrogen. Now, obviously, if you've got an ER positive breast cancer, you want to have a lack of estrogen because that's going to improve your health long term. So for those patients, it's very difficult because you can't give them estrogen. But if just say you have a stem cell transplant following a lymphoma and you have no eggs and you then don't have any estrogen, the one consequence is, say, fertility, egg donation. The second thing is, though, your low estrogen level will be very bad for your ongoing health, particularly for your bones. Your bones will become thin, I think your general sense of well-being. So for those patients, you would absolutely suggest them having HRT. That can be HRT, it can be the pill, but you would certainly suggest they have HRT, and they have HRT up to the age of 50. So people are always a bit worried about HRT. I think especially if they've had an oncology diagnosis before, because they say HRT increases your risk of breast cancer. Well, it possibly does, but that's for women who are naturally, if you like, post-menopausal, so women over the age of 50. Up to the age of 50, it's really clear benefits much greater than the risks, unless you have an estrogen sensitive diagnosis at the beginning. But for the rest of people, it does that. If you then look at what you should do with women before if they have egg donation, how you prepare the womb, we kind of do a bit of fiddling around for a few weeks to try to make it as nice as it can be, if you like, to try to put it into the best position to accept an embryo. And we may do that over like 2 or 3 months but I think the background protection of your bones is really, really important, unless you've had an estrogen sensitive tumour.
I mean, I'm on HRT because I've had a stem cell transplant, and actually, I'm also now on the Mirena coil, which has actually been quite life-changing for me in terms of actually the replacement of some of the hormones. I was a bit skeptical before I had the coil put in, but actually,
Mirenas are fantastic, absolutely fantastic. Yeah, they are really good.
And it's actually also helped with vagina dryness as well. Yeah. Something I necessarily thought about, but it's been actually quite a massive impact really for me. Absolutely,
having HRT is so important. As I say, say for vaginal dryness, your sense of well-being, for your bones, all sorts of things. It's a really important thing to have. Yeah.
So one question that's come back is, so ER positive means bone issues, is that correct?
It's very difficult for women who've had ER positive breast cancer, because obviously the treatments are to get their estrogen levels down. And one of the consequences of that is that you can then have, you'll be at higher risk of osteoporosis, of bones thinning. But obviously that's something to discuss with the oncologist, and they do work with endocrinologists to try to kind of do as much as they can to mitigate against that. Certainly as far as keeping bone health up, you don't want to be too thin, really don't want to smoke, want to carry on with lots of exercise. That's all stuff that will strengthen bones. Obviously, a reasonable diet, you can't offset the harm by taking calcium, but you want to do everything else that you can. You can't replace the lack of estrogen, but if you do everything else to minimize that risk, that's obviously important.
I would also, and menopause causes bone issues as well, with bone density and things like that. There's lots of information on the NHS website about how to improve bone density.
The menopause session we ran last night as well, which will be available on the portal, and talked quite predominantly about that. And actually the consultant was also from St Mary's that
oh right, okay.
I'm trying to remember his name, but he was very knowledgeable on that, and also talked about a number of different treatments that were available instead of HRT, but could actually be taken by hormone positive.
Yeah, so there are things. So I think it's
options.
Really important if you've had ER positive breast cancer that is part of your ongoing health care package, really.
So there's quite a few questions that are coming in about hormone replacement therapy, with some people not being able to use it because of their personal circumstances, and also people asking whether they can have private consultations with you, Dr. Cheryl.
Oh, private consultations with me, goodness. You can have NHS consultations with me.
So just to say that we're running another fertility session in a couple of days' time. The information from this session is going to be available online, and we also have a lot of other related sessions like Hannah's menopause session, which I'd be surprised if it didn't cover some aspects of HRT.
Yeah.
It was Mr. Seif that actually was in that session this night.
Yeah. So Dr. Cheryl's very kindly volunteered her time with us today, and we're not able to offer kind of follow-up appointments for everybody. But if you do post questions you have in the chat, we'll do our best to come back to you with a kind of update on some of the key themes, but we can't kind of go into detail on everybody's individual circumstances, but we can try to answer as much as we can with the remaining 4 minutes that we've got.
There's some lovely comments in the chat, Cheryl. You're incredible. Thank you very much for everything you're doing.
Oh, thank you. That's so kind of you, honestly. I just think you all go through hell. I mean, I just think it's awful. Absolutely awful. You know, you shouldn't get cancer when you're young, and then, you know, somebody says, oh, and by the way, once you're better, you're not going to be able to have a baby. And it's just awful. It's absolutely
and some of
awful.
us don't get better. You know, mine's incurable, and I'm going to have it as long as I'm alive. Which doesn't fit into any of the kind of diagnostic boxes because it's not acute. Mine's chronic personally, but others have acute incurable cancer. But thank you so much for everything today. I've personally found it really helpful, and you've clarified a lot that I consider myself an expert patient, but you've given me some really clear additional advice today that I haven't had before. So I'm sure everybody really appreciates that.
No, it's a pleasure. It's nice to meet you all.
Hopefully we'll encourage you back another time. And
you certainly can, absolutely. Yeah.
Brilliant.
Okay.
Thank you very much, everybody, for your time today. Just before everybody disappears, we have actually got a quick poll which we're really appreciative of. If you could, sorry, I found on the online ringing. Sorry about that. So if you could complete the poll for us, that would be awesome. The session today will actually be available online probably within the next few days. If you've got any bits that you've missed, or you just kind of want to listen to the discussions that have gone on today, that would be fabulous. And I am launching the poll now. So if you could all complete that for me, that would be brilliant.
If you're on your phone, tap the screen and scroll along, and you'll see 3 dots. Click that and the polls will come up.
Oh, do you think I should disappear before you do this, shouldn't I? It's really terrible. Would you recommend this? No. 1 star. Haven't you got a 0-star box?
100% of people say yes.
I believe you can do it in peace.
Thank you ever so much, Cheryl.
Okay, pleasure.
Appreciate it.
Bye.
Bye.